this week's Cardiology Countdown, we begin with a paper in the European Heart Journal looking at predicting risk of both stroke or systemic embolism in patients with Afib, but also of bleeding. There have been several risk scores that have been developed in the past year or two, and there's a comparison of the different risk scores. Interestingly, the CHADS-2 risk score is what we all have traditionally used, but the CHADS-VASC score added a few other factors, such as prior MI, prior intracranial hemorrhage, and also renal failure as factors that could predict and did predict in a large Swedish registry the risk of stroke, systemic embolism, or TIA. This was a study of over 180,000 patients in Sweden. The two risk scores that are available for predicting bleeding, has bled and hemorrhages, performed equally well, although the has bled score is easier. I think this paper illustrates these scores work well and that ever-present balance of predicting risk of thrombotic events versus risk of bleeding, something that we need to do in all patients. At the number 2 spot is a study where we don't have a publication, but was a preliminary announcement of the FAME-2 trial that looked at fractional flow reserve guided PCI versus optimal medical therapy. So this was a modest-sized trial, about 1,200 patients, randomized to those two strategies, so similar to the COURAGE trial. And the Data and Safety Monitoring Board stopped the trial early because of an overwhelming benefit in reducing hospitalization for angina and urgent revascularization in the FFR-guided PCI strategy. A press release of this finding and the stopping of the trial noted no difference in death or MI. And so this suggests that PCI done with this new physiologic measure can be very helpful in identifying appropriate patients for revascularization. And at the number 1 spot this week is a terrific paper looking at the lifetime risk of cardiovascular disease. This was a compilation of 18 cohort studies with follow-up up to 50 years. Trying to look not at the 10-year risk of cardiovascular disease as is calculated with the Framingham risk score, but the lifetime risk. And this becomes very relevant for us talking to younger patients to determine what preventive therapies we would give to them. And so they found that with increasing number of risk factors, the risk over a lifetime of developing cardiovascular disease was 4 to 6 times higher for women and men respectively, looking at mortality and also fatal coronary disease and MI. Event rates for the latter for men went from 3.6% for patients who had all optimal risk factors, that is controlled blood pressure, good lipids, no diabetes, up to 37.5% in patients who had 2 or more uncontrolled risk factors. And the numbers for women went from less than 1% for women starting at age 55 through age 80, up to 18% developing coronary heart disease death or MI. And so this gives us really a better perspective as to the long-term risk of cardiovascular disease, not a shorter-term 10-year risk, and may help guide therapies for our patients. So for this week's Cardiology Countdown, I'm Chris Cannon.